Good morning and welcome to Medicine Grand Rounds. It's really a pleasure for me to welcome you all. Happy New Year. Before we get started, I would just like to acknowledge Don Schock's wife passed away on Tuesday after 62 years of marriage. Don is with us today. I just want to acknowledge him and the role model he's been both personally and professionally to many of us here. And before we get started, I'd like to take just a moment of silence or prayer in acknowledgement of the passing of Joanne Schock. Thank you. And Don, our thoughts and prayers are with you. That being said, it's really a pleasure for me to introduce our first Grand Round speaker of the year, one of our own, from whom we can all learn a lot, and coincidentally from Don's division. Vanessa Rein is a graduate of Brown, who undertook her medical degree at Mount Sinai School of Medicine in New York. She then came to Wisconsin for residency as well as a fellowship in endocrinology. She went on to become an assistant professor of medicine at the University of Pennsylvania. And then in 2010, we were tremendously fortunate to recruit her back to the University of Wisconsin. She was promoted to clinical associate professor in 2013 and was appointed associate chief of clinical affairs by Dr. Vincent Krein in 2014. In this role, she oversees the outpatient and inpatient operations for endocrinology. She is an excellent educator, as you will see. She's served previously at Pennsylvania in various roles, and here has been an endocrine pathophysiology course small group leader and a small group leader in Patient Doctor Society. She's received teaching awards both at Penn and at the University of Wisconsin. She's physician lead for the UW Inpatient Diabetes Quality Committee. She's the lead endocrinologist who reviews diabetes practice guidelines for UW Health through CCKM. She's involved in numerous diabetes quality improvement projects and has served as lead physician in our Diabetes-Specific Joint Commission hospital certification process. Primarily, she's proud to be a clinician and spends about 50% of her time taking care of patients with diabetes. Her Grand Rounds today is entitled Taking Back Control, Strategies for Managing the Patient with Severe Insulin Resistance. Please join me in welcoming Dr. Rein.
Thank you. I'm just curious, how many people here manage people with diabetes? A lot. How many people here find it a challenge to keep up with all the new medications that keep coming out to manage diabetes? A lot. Me too. So, what I'm going to talk about today is a very challenging group of patients, the patients who seem to need tons and tons of insulin and still have these really high A1Cs. I have no conflicts of interest today with my presentation. And just want to go over an outline of what I'm going to discuss today. So first I'm going to talk about the obesity epidemic and how that's been associated with a rise in people with type 2 diabetes. I'm going to go over causes of severe insulin resistance, so obesity being the most common cause, but not the only cause. And then I'm going to spend the bulk of my time talking about medication strategies to work with this patient population. And I'm going to focus on concentrated insulins, which have really exploded in the market in the past several years. I'm going to spend a little bit of time about addressing obesity because that's the key really to getting to the heart of most people's insulin resistance. And then I'm going to go over 3 of my own patients that I've managed and show you how some of these strategies come into play. So we're going to start with the scope of the clinical problem. So I've always been a big Dr. Seuss fan, and I try to buy books for my children that I enjoyed when I was little. So one of my favorite stories when I was a child was The Sneetches. And when I brought the book home and I showed it to my son, who was 2 years old at the time, what he said to me was, "Mommy, such big bellies. So many bellies." And I thought that was interesting that he chose to focus on that while we read the whole story, but why such big bellies? And when I kind of go to public events, as you probably do too, are we becoming the Sneetches? There's so many obese people everywhere you go. I went to the Sun Prairie Corn Festival this summer, and it is an eating festival. You go there to eat the delicious corn. But when I walked into the festival, what hit me the first moment I walked in was the vast amount of obese families that I saw everywhere eating corn. So I'm going to throw out some kind of scary statistics. 71% of Americans are overweight or obese. That's almost 3 out of 4 people. It's basically becoming normal to be overweight or obese. 38% of Americans are obese, where you define obesity as a BMI over 30, but 8% of Americans are morbidly obese. That's BMI over 40, or more than 100 pounds above your ideal body weight. So this is a graph showing the change in weight in every state in America. So all the light gray lines are all the states. And you can see over time, every state has an increase in obesity. And the dark black line in the center is where Wisconsin lies. So as of the day the study was done, Wisconsin was the 14th heaviest state in America. And if you look at the incidence in type 2 diabetes, it matches that curve in almost every state in the country as well. So as weight has gone up, the incidence of type 2 diabetes has gone up. Some more scary numbers. So 30 million adults in America currently have diabetes. 95% of those patients have type 2 diabetes. So only about 1 or 2 million people in America have type 1. The vast majority have type 2. 84 million Americans right now have pre-diabetes, and most of them don't know it. That's a lot of people. And the CDC projects that 1 in 3 adults by 2050 will have type 2 diabetes. So I guarantee almost all of us are going to be taking care of people with diabetes at some point. So the increasing BMI is associated with more people needing insulin to manage their diabetes and more people having severe insulin resistance. So severe insulin resistance is defined as needing more than 200 units of insulin a day or more than 2 units per kilogram per day. There's currently no guidelines or consensus on how to best treat these patients. So what I'm going to be talking about to you today has some science behind it, but is largely based on my own clinical practice and my own experience working with patients. So there's this vicious cycle between weight and insulin use. So when people become overweight or obese, and it's predominantly central adiposity, fat around their gut organs, they become more insulin resistant. And the more insulin resistant you become, the more likely you are to take insulin. And the more insulin you use, insulin's an anabolic hormone, so it causes weight gain. So the more insulin you take, the more weight you gain. And the more weight you gain, the more insulin resistant you become. And hence this vicious cycle of trying to help these patients who seem to need more and more medicine. So treatment challenges. So taking large doses of insulin can be challenging. So one of the challenges is logistical challenge. So, insulin syringes only go up to 100 units, and insulin pens typically deliver only about 60 to 80 units per single injection. So if a patient is taking hundreds of units of insulin, they have to keep reloading syringes or keep dialing up their pen and take more and more shots. So that patient can start to take 5, 6, 7 shots of insulin a day, which they find very cumbersome. Putting large amounts of insulin under your skin, the actual injections themselves can be painful. And we see that particularly with glargine insulin because the liquid isn't actually an acid. And when you put large amounts of liquid under your skin, you don't absorb the liquid well, and you absorb it inconsistently. And so that can result in erratic blood glucose control. It's also hard to deliver large amounts of insulin via insulin pump. So most insulin pumps will only have a reservoir of about 200 or 300 units. So if you're using over 200 units of insulin a day, you have to keep filling your pump reservoir every day, which is also cumbersome. And putting high volumes of insulin through the skinny little tubing of an insulin pump can cause scarring on the abdomen. Most insulin pumps don't allow you to take a bolus more than 25 units. So if you need 50 or 60 units of insulin with a meal, you can't actually get the pump to deliver that dose. The patient has to take multiple boluses, which are time-consuming and frustrating, so a lot of them just skip it and they don't do it. And again, large doses don't get absorbed well. So I'm going to kind of look at some causes of insulin resistance. Are there any Scooby-Doo fans out there? I don't think you can even see these videos anymore. I loved Scooby-Doo when I was growing up. So for people who weren't Scooby-Doo fans, there was this group of teenagers and their dog Scooby who had to solve a mystery at every episode. So the reason I brought this up there is because I think you have to be a little bit of a detective when you see somebody who's requiring very large amounts of insulin. They very well may have insulin resistance from obesity, but there's some secondary things that can cause insulin resistance that I think are always worthy of considering. So the most common cause of insulin resistance is abdominal obesity, but let's look at some other causes. So there's physiologic causes. So I'll see this when I do consults for people in the hospital. Severe sepsis or trauma or a major surgery like open heart surgery is so stressful on the body that a person's insulin requirement can considerably increase. I can think of one time when I did a consult on a patient in the hospital who was in cardiogenic shock and sepsis. The reason I got called is because the patient had 4 insulin drips running at 60 units an hour each and had a glucose of 500. And people weren't sure what to do next. So, I mean, you can get significant insulin resistance with all that catecholamine and cortisol production during those 6 states. DKA is another source of severe insulin resistance. So someone may seemingly do well on low doses as an outpatient, come in DKA and need tons of insulin on an IV drip. And pregnancy is a cause of severe insulin resistance. And that becomes more obvious in women who have had pre-gestational diabetes, who then get pregnant and then will need tons of insulin by 3rd trimester. Medication. So we all know that steroids induce insulin resistance, but there's other medicines too. So antipsychotics is a big one. Calcineurin inhibitors, so we see that in patients who've had transplants. So tacrolimus and cyclosporin are the big players, and antiretroviral drugs as well. Kind of where I kind of always try to look at patients is endocrinopathies that can cause secondary insulin resistance. So Cushing syndrome, all the cortisol excess that patients with Cushing syndrome have makes them very insulin resistant. Acromegaly, growth hormone excess will cause insulin resistance. Significant pheochromocytoma, again, a state of high catecholamine production, will cause insulin resistance. And glucagonoma, a very rare tumor, but in this tumor, patients produce so much glucagon that their blood sugars are very hard to control. So when I see a patient who's needing hundreds and hundreds of units of insulin a day, I always kind of step back and think, do they have features of Cushing syndrome? Should I be screening for that? Maybe I should be looking for acromegaly, or just make sure that there's not some underlying reason for the insulin resistance, not just manage the diabetes, but see if I can find another cause that I can treat. There's some rare genetic syndromes of insulin resistance, and there usually will be either family history of severe insulin resistance or some phenotypes that you'll see. But there's defects in insulin receptors or patients who make insulin receptor antibodies. These patients will often need hundreds to thousands of units of insulin. There's a rare syndrome called Hare-Ann syndrome. Hare-Ann syndrome is basically like super severe PCOS. So women who are not just hirsute, but actually virilized, they can often have huge insulin requirements. And congenital lipodystrophy syndromes actually have one patient with a congenital lipohydystrophy syndrome where he has almost no fat on his face or extremities and has a very huge abdomen requiring a lot of insulin. There's some acquired conditions. People can develop anti-insulin antibodies where they basically like attack injected insulin and so it doesn't work. Acquired lipodystrophies that can be seen in HIV. And then I kind of wanted to mention pseudo-insulin resistance. So what I mean by that are patients who appear to be very resistant to insulin, but there's really some other reason why insulin isn't working right for that individual. So poor insulin technique, I think it's important to ask people, how are you taking your injections? How do those go? So for instance, sometimes patients will say, I give myself a shot, and when I take the needle out, all this liquid is on the top of my skin. So it means that they didn't leave the needle under their skin long enough, and the insulin leaked out of the needle tip when they pulled the needle out. And that can be seen when people take really large doses of insulin. It takes a long time to push all the insulin from an insulin pen through the needle, and they have to leave it under their skin sometimes for more than 20 seconds. So it's not that the insulin's not working, the insulin's just not getting in their body. So I think it's interesting to ask people about how are they using their insulin, how are the injections going, how are they storing their insulin. I had a man tell me the other day that he's been using insulin that he keeps in a box in his basement for a few years now. And I was like, do you refrigerate? You have to refrigerate the insulin. He's like, oh no, it's just in the basement. I'm like, that insulin doesn't work. It's expired. It wasn't refrigerated. So ask people, how are they storing their insulin? How are they taking it? And I think it's important to look at their injection sites. It is pretty common to find that patients have something called lipohypertrophy. So lipohypertrophy is scarring under the skin that occurs from repeatedly using the same injection site over and over and over. So sometimes I've looked at people, and when I look at their belly or wherever they're injecting insulin, it's almost like this hard ball is either under their skin or protruding from the surface of the skin. And they tell me, I keep using that spot. And I'm like, you're basically injecting insulin into a ball of scar, and it doesn't absorb. So what will happen is that person will be taking insulin and it's not working. And you raise the dose and they try it and it doesn't change anything. And you keep raising and raising and raising the dose and it's not making any impact because they're injecting into an area of their skin that doesn't actually absorb any of it. So I think it's important to ask these questions before you assume that the medicine's not working or the dose isn't right, to make sure that there's not a logistical reason for why the insulin doesn't seem to be making an impact on that patient's blood sugar. So I'm going to spend the bulk of my time now going through medications. So another favorite book of mine when I was growing up in grade school were Choose Your Own Adventure books. Has anybody heard of those before? Yeah, so I don't know if they still have them in children's libraries. I loved these books because you could pick up the book and read it and take a different adventure every time you read the book. So when you open the book, you would read a few pages, and at the end of a few pages, there'd be a question. If you want to take the road to the left, go to page 10. If you want to take the road to the right, go to page 15. And you could keep reading the story and have different journeys and have different outcomes. I loved it because you could enjoy the story over and over so many different ways. And I kind of feel like that's how diabetes management is at this point. There's so many options that you can really, everybody has to be very individualized in their care, and you have to really, you can navigate so many different paths to try to get to that patient's end goal, good glycemic control. So what do we have in our toolbox to use to help manage these patients? Well, we've got oral agents, we've got non-insulin injectable medicines, liquid medicines, we have insulin, and we have insulin pumps. So because there's so many drugs out there on the market, I just wanted to kind of bring everybody up to speed on what some of the options are for people with diabetes. Because I really find, sometimes I have referring providers tell me I'm good with metformin, and I'm good with the sulfonylurea, and I'm kind of lost after that. Or I'm good with glargine insulin, and I don't know what to do past that point. So I kind of wanted to just review what we've got as choices. So we have metformin. I think most people are familiar with metformin. And metformin's a really great drug because it really targets the key problems in type 2 diabetes. It blocks gluconeogenesis and it reduces insulin resistance. We also have GLP-1 agonists or incretin mimetics. So these are all liquid medicines that are injected, and they're injected either once daily or once weekly. And what they do is they tell your pancreas to make more insulin when your blood sugar is high, and that's particularly seen after meals. We have TZDs. So TZDs also are really great at reducing insulin resistance in patients. Sulfonylureas, most of you are probably using those. Sulfonylureas tell your pancreas to make more insulin all day long. DPP-4 inhibitors, so this is a newer class of medicines that block degradation of your natural GLP-1 in your body. So the result of it, it's almost like a really, really mild form of a GLP-1 agonist. It reduces glucose, particularly after meals when glucose is high. The newest class of oral agents, SGLT2 inhibitors. So these drugs block the kidney from reabsorbing sugar out of the urine, so they increase urinary wasting of sugar. And then we have all kinds of insulins, basal and prandial insulins. So there's a lot of decision making on how to pick a drug for a patient. You think about what is feasible for the patient, what can the patient afford. I also look at how strong is a drug and where is my patient's A1C and what do I need to get them closer to goal. So I kind of grouped drugs in terms of potency in lowering A1C. So I have strong, intermediate, and mild. And the reason I mention that is because sometimes I'll get a patient referred to me who's taking tons of insulin, their A1C is 12 or 13, and someone just added a DPP-4 inhibitor. And I look at it and I think that's just so not worth it, because the DPP-4 inhibitor will lower that A1C maybe 1% at best, but that patient is so far off target, it doesn't make sense that that would be the next best thing to add. So that's why I kind of stratified it by potency. So clearly insulin is the most potent thing you can give a patient. Insulin can drop a patient's A1C any percent if you give them enough. So, you can drop it 6% if you want to. But the next strongest agent that you can give a patient is metformin. So metformin can drop someone's A1C at least 2%. I've sometimes seen 3%. It's very, very strong. And then the next strongest agents are the GLP-1 agonists. They will drop your A1C about 1.5%. Everything beyond that is less potent. So TZDs and sulfonylureas give you maybe 1% to 1.5% drop in A1C. And all the newer agents that get a lot of buzz right now because maybe of cardiovascular risk reduction and whatnot, they really lower your A1C a very small amount, maybe 0.5% to 1% at best. So I when I'm looking at patients that are really struggling with control, I kind of look at my agents that give me a lot of potency because I have a lot of room that I have to work with to get that A1C down. The other thing that I kind of look at when I'm choosing a drug is how does it affect your weight? Because so many of these patients have obesity that is really the heart of what's driving their diabetes. So I think it's preferable to try to use drugs that promote weight loss. So metformin, GLP-1s are drugs I use a lot. SGLT2 inhibitors do cause some weight loss, but again, remember, their potency is very weak for lowering blood sugar. And then you have DPP-4 inhibitors are weight neutral. They don't impact weight at all. And then, unfortunately, TZDs, which are really great for reducing insulin resistance, can cause a fair amount of weight gain in patients. I've seen more than 20 or 40-pound weight gain in some patients, and insulin certainly causes weight gain too. So what I have to do when I look at these patients is I have to balance what do you need to get glucose control and how's that going to affect your weight? It's a tricky balance because sometimes the best drugs for that patient is insulin, unfortunately, and it does cause more weight gain. But I think it's helpful to think about how weight gets impacted by a drug while you're choosing a drug for your patient. So I'm going to give you some of my own personal recommendations as we go through these medicines. So my first recommendation is every patient should be taking metformin unless they can't tolerate it or is contraindicated. And the reason I say that is because sometimes I meet patients who are on large amounts of insulin, they're not on metformin, and I'll ask the patient, were you ever on metformin? And they'll tell me, I was, but when my doctor added insulin, they stopped it. And that's really a mistake because metformin reduces your insulin resistance and keeps the insulin dose you need down. So it's very valuable to keep metformin in that person's medication regimen. And if they have trouble tolerating higher doses, even staying on lower doses is still worthy. So everybody should be on metformin. When I see someone who's not on metformin, I sit there and think, why aren't they on metformin? I want to go find a reason why they can't be on it. Otherwise, I'm going to give them metformin. So metformin's generic. It's very well tolerated. It induces some weight loss, and it potently lowers glucose, at least 2% reduction in A1C. It reduces insulin resistance, and it helps keep insulin doses down. I will even use metformin in an off-label use of it in type 1 diabetes if I have an obese patient with type 1 diabetes. I don't see that a lot, but sometimes I'll have a morbidly obese patient who has type 1 diabetes. I will add metformin to that patient because that patient's obesity creates resistance to the injected insulin that they take, and they still need really large doses of insulin. And when I have had to stop metformin for a patient because they develop a contraindication to it, I've sometimes had to double their insulin dose over time to make up for the lack of the effect that they're getting from stopping the metformin. And I also mentioned now that it's safe to use metformin in stage 3 chronic kidney disease. So years ago, we were all taught that you can't use metformin with chronic kidney disease because there was a risk of lactic acidosis. And there have been some more recent meta-analyses that have showed that that risk of lactic acidosis is actually really, really small. And it's actually safe to use metformin down to a GFR of 30. So if someone's GFR is over 45, you can use maximally effective doses of metformin. And that's a change from what I was taught when I was in training. And you can use half maximal effective doses if their GFR is between 30 and 45. So again, this should not be a reason why someone is not on metformin. So my recommendation number 2, consider adding a GLP-1. So this class of medicine is also generally well tolerated. It has 2 beautiful side effects. It takes away your appetite and it causes weight loss. And most patients, when they hear about those side effects, are all ready to sign up for this injection. They love those side effects. They also can reduce insulin resistance, so when added to a patient's regimen, they can help reduce their insulin requirement. They also potently lower glucose, and they do so more after you eat. And they're pretty easy to take. So their injections are either once a day or there's a few brands that are actually once a week. So most patients are not opposed to taking another injection if it's once a week. So recommendation number 3, optimize the use of concentrated insulin. So using concentrated insulin allows that patient to absorb insulin better, so it works better in that patient, and it helps reduce the number of insulin injections they take. So we usually tell patients when your dose is over about 50 units of insulin at one time, that amount of liquid injected in the skin is very difficult to absorb. So when people take more than 50 units, I tell them to start dividing their dose into 2 shots. So if you need to take 90 units of glargine for basal insulin, I'll tell them put 45 units in one spot, move over and do 45 units in another spot. But what about the patient who takes 400 or 500 units of insulin a day? Start thinking about how many shots that actually is to take. So by using concentrated insulin, you can give them those high doses in smaller volumes of liquid and in fewer shots. So I'm going to spend some time going over these concentrated insulins because a lot of people feel like it's this like foggy class of stuff that just keeps coming out and people don't understand what they are. We had this explosion in 2015 and 2016 of like every other week a new drug was being marketed as coming out to help diabetes. But it's only really been in the last year or so that our local insurance formularies are actually covering some of these medicines. So even though they've been out for a few years, it's only really recently that we've actually been able to get patients to use them. And I think in 2018, you're going to see that some of our formularies are now putting some of these insulins on without a prior authorization. So U300 glargine. So U300 glargine is a long-acting basal insulin, and it's basically glargine that is 3 times concentrated. So it allows a patient to get the same dose of U100 glargine in 2/3 less liquid. So all insulin that is conventionally made is U100 insulin. So what that means is there's 100 units of insulin per milliliter of liquid. So all the insulins that we've been using for a long time are called U100 insulin. So U300 insulin means that there's 300 units of insulin per 1 milliliter of liquid. So it's the same glargine medicine, but it's 3 times stronger in 2/3 less liquid. It only comes in a pen. So what's interesting is U300 glargine has a little bit different pharmacokinetic profile as the traditional U100 glargine that we use a lot. So U100 glargine has a duration of action of about 18 to 22 hours in the average adult, which is almost the whole day. And because it doesn't always last the whole day in some patients, that's why some patients take glargine twice daily to get full day coverage. U300 glargine has a duration of action of at least 30 hours, so one injection truly should last the patient the entire day. You can only take up to about 8 to 80 units at a time in this pen, and you do take it once daily, but you have to take it at the same time every day. It's less bioavailable than U100 glargine. So what I will notice and what some studies have showed is that if you have a patient taking 70 units of U100 glargine and you convert them to 70 units of U300 glargine, you notice that their blood sugar goes up a little bit, and it's because the bioavailability is a little bit less of the concentrated insulin. So you often have to raise the dose of U300 glargine 10 to 20% to match the effect that they were getting on the U100 glargine. So this is my personal opinion, but I feel like U300 glargine is a really good choice for the insulin-resistant patient who's is less severely insulin resistant, whose basal insulin dose is about 50 to 80 units. And the reason I say that is because the pen only goes up to 80. So if you are trying to give a patient a higher dose than 80, you're mandating that they take more than one shot, which is one reason why I sometimes want them to go on concentrated insulin in the first place. And because when I switch over, they're going to need a little bit more insulin, and the more you take, the more weight you gain. So my thought is, I think it's a good choice, but I think it's a good choice for someone who only needs maybe about 50 to 80 units of basal insulin a day. So we have another insulin that came out after U300 glargine, which I think has a lot of good potential in our patients who need a lot of insulin. So this is something called degludec. So degludec is an ultra-long-acting basal insulin, and one shot has a duration of action of 42 hours. And it comes in a U100 strength, and it comes in a concentrated U200 strength. So One really cool feature of degludec is that after you take a shot a day for 3 days straight, you hit a steady state in your blood such that your injections no longer need to be taken at the same time every day. As long as you get the shot sometime in that day, you will have a consistent level in your body. So what the company markets says, you can take degludec at any time of day, at least 8 hours from the last shot that you took. I think that's a really great choice for a shift worker, maybe a patient who's a nurse who works day and night shifts, a patient who may not always remember to take a shot, forgot to take it this morning, doesn't remember until lunchtime that they forgot their shot. It really gives you flexible dosing with time. The U200 pen, so this is insulin that is twice as strong as U100, can allow a patient to take up to 160 units in one injection, and it will give you the same dose as U100 degludec in 50% less liquid. Interestingly, U200 degludec appears to be more potent than U100 glargine. So when I have switched patients so if I've had a patient on 100 units of U100 glargine, and I switch them to 100 units of U200 degludec, they start getting low blood sugar. And it's the U200 degludec is stronger. So I usually have to cut the dose back about 10 to 15% when I make that conversion, but that's awesome because they get a better effect with a lower dose, less weight gain. So I think that's a really cool feature of this insulin. So my thought is U200 degludec is a really good choice for patients who have more moderate degrees of insulin resistance and they have basal insulin requirements of maybe up to 160 units a day. It allows them to get that dose in a smaller amount of liquid in a single shot. And then there's U500 insulin. I think of U500 insulin as my desperate insulin when I have a patient that just needs so much insulin that I just don't know what else to do. U500 insulin is 5 times stronger than conventional U100 insulin. So it allows you to give a patient a very large amount of insulin in 80% less liquid than if you gave them the same doses in U100 insulin. U500 insulin has both basal and prandial insulin properties. So when you switch a person to U500, you usually switch them to U500 insulin only. So U500 insulin, when you take the shot, it starts to kick in 30 minutes. So if you take that shot before you eat, it will somewhat cover that meal. And it starts peaking in about 3 to 4 hours and lasts maybe 12 to 18. So it has a little bit of a basal component too. So when I've had patients who are doing really poorly on hundreds and hundreds of units of insulin, when I switch them to U500 at an equivalent dose, I often notice that blood sugars sharply come down. And it's often simply because I'm giving them so much less volume of liquid that they absorb it well. If someone is injecting hundreds and hundreds of units of insulin a day, they're just not absorbing it. It's just not going anywhere. It's not working. And because it serves as both basal and prandial insulin, it allows the patient to only have to buy one insulin, which is cheaper for the patient. It now comes in a pen. And all endocrinologists were like, hallelujah, because there were so many problems with the insulin in the vial, because you would have to tell the patient to use a U100 syringe and draw 5 times less in the syringe than their actual dose, and it just led to so many math errors with patients. The new pen auto-adjusts all the volume for the patient so they don't have to do any math. I want them to take 100 units, turn the pen to 100, and inject. So much safer for the patient. This pen allows a patient to take 300 units of insulin in one shot. So you can dial it all the way up to 300 and get it all in one shot. And it's fortunately aqua blue, so it stands out from all other insulin pens, which tend to be gray or navy. So it's less likely to be the wrong pen a patient chooses, and there's less mistakes. I get a lot of questions from providers on how to switch a patient onto U500 insulin. So I put this table up there just to give you a rough guide of how we convert someone from U100 insulin to U500. You should start to think about it if a patient's total daily insulin dose is over 200. So between 200 and 300 units a day, I typically give the patient 2 shots of it, 1 shot at breakfast, 1 shot at supper in a 60-40 split. When the patient starts to need between 300 and 600 units of insulin a day, I take that total daily dose of insulin and I split it into either 3 or 4 shots. More insulin earlier in the day, less insulin later in the day, because the insulin will stack since every shot lasts 12 to 18 hours. By the end of the day, some of the earlier doses are still in effect with the later doses, so I give them a lot less in the evening. So I'll either do a 40-30-30 split with each meal, or I'll do 30-30-30% at each meal and 10% at bedtime. And for patients who need more than 600 units a day, I typically use 4 shots of U500 a day in a 30-30-30, 10% split. We have one concentrated mealtime insulin on the market at this point, and it's called U200 Lispro. So it delivers the same amount of Lispro in half the volume if they were to take U100 Lispro. Unfortunately, they can only dial up to 60 units at once on a pen, which I think is somewhat limiting, because I really feel like you start to think about using concentrated mealtime insulin when the dose is about 50-ish or higher. So unfortunately, if they need 70 or 80 or 90 units with a meal, they do have to take 2 shots, but they do absorb the insulin better when it's concentrated. U200 Lispro works exactly the same as U100. The pharmacokinetic profile is identical, so there's no differences with potency or timing of the insulin. And insulin pumps are still an option for a patient with severe insulin resistance. So we actually have some newer pumps that have come out recently that have reservoirs of almost 500 units of insulin. So it allows a patient to be on a pump and not have to fill it every day or more than once a day. And it can allow a patient to take up to a 60-unit bolus at once with a meal. So that's a really great feature that really has been a barrier to patients on insulin pumps in the past. And just off-label, endocrinologists will often use U500 in a pump, especially when patients start to get in the thousands of units of insulin they need per day. So my final recommendation is address obesity, because obesity really is the heart of most patients' severe insulin resistance, and we're not really serving our patients well if we don't address that root cause. So one of my daughter, I have a 9-year-old daughter, and she loves Shel Silverstein. Has anybody read Shel Silverstein before? Great author who writes a lot of poems that have humor and satire and irony in them. And this is one of the poems from the book. It's called Scale. And I think it really highlights the denial that some patients have about their weight. So the poem says, "If I could only see the scale, I'm sure that it would state that I've lost ounces, maybe pounds, or even tons of weight. You'd better eat some pancakes, you're skinny as a rail." I'm sure that's what the scale would say, if I could see the scale. So again, I feel like we really have to be proactive in looking at patients' weight and addressing it with them. So what might be some barriers to us looking and addressing weight issues with our patients? So one could be, I didn't learn how to do this in residency, or the patient's not motivated to lose weight, or what I say isn't really going to change their behavior, or I don't have time. We don't have enough time today to address that. So treatment of obesity in our patients with diabetes and otherwise really should include individualized medical nutrition therapy. I feel like all those patients should see a registered dietitian for some individualized counseling on what to do with their meal plan. patients have to exercise. I can't even emphasize that enough, that patients think that if they just eat salad for lunch 3 days a week, that the pounds are gonna melt off. You have to burn more than you put in. You have to exercise. And behavioral modification, and the reason I put that in there is because so many people are emotional eaters. They eat because they're sad, they're lonely, they're bored, because it's social. And we really have to look at what are some of the reasons why people are eating. And a lot of patients, you can't just tell a patient you're overweight and you need to lose some weight. That's just not really effective for that patient. That's like telling a patient with depression, just cheer up. Like, it just doesn't work. Like, if you just tell a patient you have to lose weight, you have to be very specific and give them a targeted goal. So to get a glycemic benefit, we usually recommend that you try to lose 5% of your body weight. So I'll look at a patient's weight, I'll quickly calculate what about 5% might be, and I'll tell that patient, you know what? I would love it if you could lose 15 pounds. If you lose 15 pounds, you will see a big benefit on your blood sugar. And start working on a time frame for how we could get those 15 pounds. I think if you can give people a concrete goal to work with, it makes it easier for them to approach it. And it has to be something reasonable. You can't sit there and say you really have to lose 120 pounds. I mean, that's just so overwhelming that it's going to make a patient panic. I think it would be ideal if they could lose 7% or more of their weight and maintain that, but at least strive for 5%. According to the ADA, the American Diabetes Association, this is their official exercise recommendation. 150 minutes of moderate to vigorous aerobic exercise per week, at least over 3 sessions. So in other words, you have to break a sweat when you're exercising. Like, yoga wouldn't count. So I think it's important to tell patients what the exercise expectation is. This is what the ADA recommends. I will tell you, in my personal experience, sometimes patients are doing this much exercise and they're maintaining weight. So often I will kick that up and say you have to go to 200 minutes. You have to go to 250. You've got to work out 45 minutes most days of the week. And I give them some parameters to work with. But the point is, you have to move. You can't be sedentary. And I also want you to think about the fact that some of these patients who are very obese, you have to figure out if it's safe for them to exercise from a cardiovascular standpoint, from osteoarthritis standpoint, etc. So while we want to have people eat well and we want them to exercise, the reality is it's hard to lose weight and it's really hard to keep the weight off. So something I think we always want to think about, what are other tools that we can draw upon to help that patient who's struggling with weight? So weight loss drugs should be something you think about or the patient considers if their BMI is over 27 and they have weight-related comorbidities. So that would be things like diabetes, hypertension, dyslipidemia, coronary artery disease, obstructive sleep apnea. Any person with a BMI over 30, and you can expect to get perhaps a 3 to 6% loss in weight at 1 year using these drugs. I think that's also important to tell people so they have a realistic view of where they're going to go with these weight loss drugs. And for people where bigger weight loss is a goal, bariatric surgery is something that we should think about. So bariatric surgery would be indicated with a BMI over 35 and weight-related comorbidities, or anybody with a BMI over 40. Bariatric surgery has the potential for a patient to lose huge amounts of weight. I have seen patients that I thought preoperatively they will lower their medication dose, but they'll probably never be medication-free because they're on so much medicine right now. They've had bariatric surgery and within the first year have lost more than 100 pounds and they are medication-free. I have definitely seen that many times and it amazes me every time. So, this is from Charlie Brown Christmas, where Lucy pretends that she's a doctor and offers help to her patients. but I just wanted to go over 3 patients that I have seen to kind of show you how I put some of these tools into play and how it worked out. So case number 1, a 57-year-old man who's had type 2 diabetes for 18 years. His highest weight was 310 pounds with a BMI of 46. He had a Roux-en-Y gastric bypass 7 years prior and did lose 70 pounds with the surgery, but has gained 20 pounds back in the last year or so. He came to me taking Glargine 100 units a day, Lispro 90 units with each meal, so almost at 400 units of insulin a day with an A1C of 10%. So just stop and think for a second, what would you do? What would you do to help this patient? And so my first thought when I saw this patient is, why are you not on metformin? And he said to me, I was on it, but when I had mealtime insulin added, it got stopped. So my first thought was, add the metformin back in. And I tend to add one thing at a time initially because when I have added more than one medicine at a time and they get a side effect, I don't know which drug it is. So I added metformin first for 3 months. Then I added liraglutide, a GLP-1 agonist, at the maximal dose daily. And he had a fabulous response. So within the first year, he lost 40 pounds. His BMI was down to 33, his thinnest adult weight. When I started adding these, especially when I added the liraglutide, he started getting hypoglycemia. So I had to keep cutting back on his insulin. And the more weight he lost, the less insulin resistant he became. So he needed even less and less insulin. And then being on less insulin, you don't keep on as much weight. So at a year, his Glargine dose was down to 20 units daily, Lispro down to 10 units daily with each meal, and his A1C came down to 6.6%. Pretty awesome. So case number 2, a 64-year-old man who actually has type 1 diabetes for 32 years, but he's obese by BMI. His BMI is 33. He came to me with MPH 50 units twice a day and regular units 30 twice a day with an A1C of 8.5. And he was frustrated because he felt like I check my blood sugar, I take my insulin every day, and my A1C is always elevated. How can I do better? So trying to think about what I would do to kind of help this individual. So first I switched him to conventional basal bolus therapy. I switched him to Glargine 35 units twice a day, and I split it because I didn't want to give him all 70 units in one shot. I put him on Lispro at a 1-to-3 insulin carb ratio, and his A1C didn't really budge all that much at 8%. So then what we did was I switched him to concentrated insulin. So I switched him to U300 Glargine, but I had to go up on the dose a little bit to 80. I switched him to U200 Lispro at the same insulin to carb ratio, and his blood sugars immediately came down, and his A1C went down to 6.8%, simply because he was absorbing the concentrated insulin better. And then my last case, a 58-year-old woman with type 2 diabetes for 7 years, BMI 45. So when I met her, she was taking glipizide 10 milligrams twice a day, max effective dose, metformin 1,000 milligrams twice a day, max effective dose, Glargine 95 units twice a day that she was doing in 4 shots, and Aspart 30 to 50 units with each meal, and her A1C was 9. So just kind of looking at this patient, just think for a moment, how would I approach this patient? So my first thought with her is, why is she on glipizide? Doesn't really make sense to be on glipizide, a medication that tries to get you to make more insulin when you're taking nearly 400 units of insulin. So I stopped the glipizide, I kept the metformin, and I put her on U500 initially. And I think I did that because when I first started seeing this patient, we didn't have some other concentrated insulins available yet. But I switched her to 3 shots of U500 insulin a day. And her A1C came down. It came down to 7.9%, but her BMI went up to 53. She actually gained a lot of weight because she was taking a lot more insulin and absorbing it better. So what I then did was I added a GLP-1 agonist. I added extended release exenatide once a week. Her U500 doses were then substantially decreased, and I was able to give her just 2 shots a day. A1C went down to 7.2, and her BMI did drop a little bit more, back to 49. So I wanted to just show you some of these cases to try to tell you that some of this does actually work, but it does have to be very individualized. So I'm hoping that some of the newer medicines sound more familiar to you. It's not so mysterious. You can see how some of them work. Remember, metformin, GLP-1s. Think about concentrated insulins, or at least refer your patients to us to think about concentrated insulin. Think about screening for hormone conditions that might cause insulin resistance, and really try to address obesity. Thank you.
Thank you very much. We've got time for maybe 1 or 2 quick questions and quick answers. So please provide us your question, and if you don't mind repeating.
Sure.
That'd be great.
It's wonderful to hear Grant Round as a master clinician. Thank you. We have a lot of transplant patients and HIV patients at the center, so we can anticipate they're going to need their calcineurin inhibitors, their protease inhibitors, and they're going to get the dystrophies and such. Are we doing enough on the front end to prevent them from getting to this point, knowing that the population is going to develop insulin resistance at a pretty high rate over time? Are we applying those 3 behavioral and other treatments that you're proposing that we do?
It's a good question. I know that transplant does actively counsel patients pre-transplant that diabetes is very likely post-transplant. So I don't think it's a shock to those patients, and they are aware that that's a potential risk. I think that, and sometimes we'll get patients sent to our clinic pre-transplant to try to optimize them before they even have their transplant. But how much active counseling with weight, I don't know. I mean, I think it's a very good thought, because a lot of those patients, especially with prednisone post-transplant, gain middle. You know, they gain central adiposity. So I feel like it's a really important thing to recognize. I don't know how much active weight counseling is done before some organ transplant, but it's certainly something we should think about.
We're going to have to close there. I want to thank Dr. Rein for an outstanding Grand Round.
Thank you.